this series of webinar. I'm Jing Liu from Peking University People's Hospital. It is my great pleasure to host today's webinar. Tonight's theme is adherence imperative in hypertension management. As we all know that the hypertension control rate is still very low in China as well as in many Asian countries. One of the biggest problem may be the low adherence in among the people who are treated with blood pressure lowering medications. And for the improvement of the blood pressure control in China as well as in China, as well as in Asia regions, we are glad to invite two distinguished speakers to join us for this tonight's discussion and for the topic presentations. I would like to introduce the first speaker, Professor Felix Mahfoud. Professor Felix Mahfoud is a professor and director of Department of Cardiology at the University of Basel. Professor Felix Mahfoud has been involved in many society in the field of cardiology as well as heart failure. He is currently the ESA board member, chairman of ESA Communications Committee, and also the chairman of European Society of PCI Scientific Documents Committee. He has published many papers. More than 500 peer-reviewed articles has been published in journals. Or his H index is 77. He has major in recent years. He has do a lot of work on the renal denervation and the coronary and cardiac intervention procedures. The second speaker is Professor Jing Li from Xuanwu Hospital. Professor Jing Li is a chief physician and professor as well as a doctoral supervisor at the Department of Geriatrics of Xuanwu Hospital, affiliated Capital Medical University in Beijing. Professor Jing Li is also involved in many societies, such as in the Society of Geriatric Medicine, as well as Beijing Hypertension Prevention and Treatment Association. Professor Jing Li also a fellow of European Society of Cardiology. We are also very glad to invite two panelists from Beijing to join us for discussion. The first one is Professor Lei Li from Peking University Third Hospital. Professor Lei Li specialized on long-term anticoagulation management of atrial fibrillation patients. He also very interested in the cardiac remodeling and the mechanism study of atrial fibrillation. Professor Lei Li has been a visiting scholar at the University of Michigan of USA. The second panelist is Professor Zhuang Tian from Peking Union Medical College Hospital. Professor Zhuang Tian is a chief physician and doctoral supervisor at Peking Union Medical College Hospital. he is majoring at the treatment of heart failure as well as cardiomyopathy. She has published a lot of high impact papers such as at the JAMA Cardiology and Signal Transduction and Targeted Therapy. And welcome all the speakers and panelists. The first presentation will be Professor Felix Mahfoud. He will give us a talk about the importance of improved adherence in hypertension management. Now, Felix, welcome.
Thank you, Prof. Jing. I hope you can hear me and see my slides.
Yeah, you can.
Yes. Okay. Thank you very much for the kind introduction, but also for the opportunity to be with you and to discuss with you a matter that is really important in the treatment and management of patients with hypertension, and that is adherence to medication, or you can even expand it and say adherence to lifestyle modification, because this is a tough issue as well. These are my potential disclosures. Well, whenever we see patients, and we see patients, let's say, with uncontrolled blood pressure, or patients with LDL cholesterol above target, or patients with an ABH1C above target, we have to ask ourselves one very relevant question. And that is, why does an principally effective therapy fail to work in an individual patient? And there are only two options. Number one is that the patient is non-responding to the therapy. So we prescribe a drug, but the drug is taken by the patient, but not doing what we supposed it does, meaning lowering blood pressure or lowering LDL cholesterol, for instance. Much more frequently is non-adherence to medication. So whenever you see patients failing to achieve any guideline recommendation, ask yourself whether the therapy is not working or whether the patient is just not taking what we are prescribing. And it's very simple, right? But we need to take that by heart and seriously, because drugs don't work in patients who don't take them. That's a very simplistic statement here put forward by Dr. Koop, who was the Surgeon General back then in the 1985, where he described this as being a common phenomenon in patients with hypertension. So keep that in mind whenever you consider patients not achieving what you think they should or what you are aiming for in an individual patient. Adherence is much more than just compliance. And I want to do some semantics here, because it's relevant to patients and physicians alike that we use the same language here. So compliance is the old terminology, and it's more paternalistic. So you decide, we as physicians decide what is best for the patient, and the patient should follow the instructions then. So this is more a directive approach to the issue. More modern and contemporary is the terminology adherence. And here it comes to shared treatment goals and the implementation of an agreed therapy. Typically, we start with lifestyle, then we prescribe medication, and the choice of medication should be made together with the patient. It's not only our decision which drugs to prescribe, but we should seriously take the patient's preference and their expectations into consideration as well. So that's the difference between compliance and adherence being the more contemporary word. How can you assess adherence if you're really asking yourself what I've just put forward, the question, which is, why is the therapy not working? And it's very easy, right? So if you don't measure adherence, you can't find patients who are non-adherent. So it's rare when you don't measure it, but it's very frequent when you do measure it in clinical routine. And this slide here shows the options that we have to measure adherence in clinical practice. Very easy is the patient interview. You ask the patient, are you adhering to medication? We'll go through that in a second. You can look into patient diaries. There are adherence questionnaires, such as the Morisky medication scale, 4 questions or 8 questions that can be answered with yes or no, and then you got a score at the end that then tells you on whether a patient is likely non-adherent or adherent to therapy. More objective then is the prescription record review. You can assess on how frequently you have prescribed the medication to a patient. In clinical trials, we frequently utilize pill count. So we ask the patient to bring all the pills to the visit, and then we calculate how many pills have been taken from the last visit to this visit. And then we have electronic monitoring, meaning you have special boxes. Once the boxes are open, you see that the patient has opened the box and it's registered. It's not telling you that the patient swallowed the pill. They can throw it anywhere in the toilet or in the bin, but it's at least telling you that the patient opened the box. And there is some association, of course, between opening the box and swallowing the tablet. And then there's something which is very accurate, and I do that also in clinical practice, which is directly observed therapy. So whenever, let's say I have a patient with seriously resistant hypertension or refractory hypertension, very high blood pressure on multiple medication, and I'm just wondering why the hell is the patient not responding to therapy? And he or she is telling me, well, I'm taking all my drugs. I don't know why. It worked for a while, but now blood pressure is exceedingly high. What I then do is I ask the patient to come in the morning and take the drugs under surveillance of a study nurse or a physician. And then we place an ambulatory blood pressure reading monitor, blood pressure monitor. We place it, we measure blood pressure, and then we assess the directly observed therapy blood pressure, which is in various cases I've seen significantly lower than the average blood pressure measured without directly observed therapy. So this is then also an indication of non-adherence to medication. The most objective, and you can see it here on the far right-hand side too, the most objective measure of adherence for sure is the toxicological analysis in urine and plasma, where we assess components of the drug or the drug itself being metabolized in our bodies. And then we can say not only whether the patient has taken the drug, but we can also estimate when the patient has taken the drug. So that's quite useful in certain patients, when you believe you need an objective measure of adherence to medication, and we do that also quite frequently in clinical trials. Speaking about resistant hypertension, or in this context, better, apparently resistant hypertension, we see a lot of these patients presenting to our institution on 3, 4, 5 antihypertensive drugs. And when you look into meta-analysis dealing with this topic, you can find one here that comprised 9 clinical studies where they measured adherence in apparently resistant hypertensive individuals. And it's surprisingly high. Look at this, almost 20% of all patients did not take a single tablet. 1 out of 5 patients was completely non-adherent to therapy. And 44% of the patients, every second patient almost, was partially adherent to therapy, meaning that in these individuals with apparently resistant hypertension, we have a very high chance that patients are non-adhering to the prescribed antihypertensive medication. Indeed, every second patient is partially or completely non-adherent to medication. So think about it, assess it, because it also associates with poor outcomes. This is another meta-analysis comprising 44 studies with more than 2 million participants. They were on medication in cardiovascular diseases. And when you look into this, you can see that patients who were adherent to any medication, you can find it here, adherence to statins, for instance, reduced the relative risk by 15%. Adherence to antihypertensive agents reduced the risk for cardiovascular disease by 19%. And when you pool it, 135,000 events, 1.6 million participants, you can see that the relative risk reduction is 20%, indicating that patients who are adhering to medication are those who have better outcomes as compared to patients who are non-adhering to prescribed antihypertensive medication. And we also used these data to calculate that round about 10% of all cardiovascular events worldwide are attributable to poor adherence to medication, which is a huge issue, right? So that means indeed that a lot of patients are just not adhering to medication and thereby increasing their individual cardiovascular risk, which is then unfortunate and, of course, in principle, preventable. When does non-adherence arise? And there are certain aspects to be considered. So primary adherence is when you initiate a therapy. So you talk to your patient, you initially prescribe a drug, and then you recognize that there are two options, right? One option is that the prescription is not filled or that the medication is not taken by the patient. That's the first step of adherence to medication. And it's really astonishing when you look at this, right? More than 400,000 electronic prescriptions from more than 280,000 patients. 26% of all newly prescribed antihypertensive medication is never filled. And diuretics is 30% never filled. So you do a prescription, every third patient is never filling that prescription, not even going to the pharmacy to get the drugs. They're just not taking it. They don't consider this being an important aspect, which is why they're not filling the prescription. Next step is the represcription. So patients were initiating the therapy, but then you have to implement it, right? And what happens during implementation is that patients forget the dose, that they take an additional dose, that they have an incorrect timing of the intake, that they have stock pilling, and that they repeat prescription filled too late. And this is an issue too, right? And then there is the continuation phase, and the continuation phase can be prematurely discontinued, and this is then the end of therapy. And what you want to achieve, what we want to achieve is persistence to therapy. So we want patients not only to adhere short-term, but also long-term, to have a long-term treatment adherence to whatever we prescribe. Sorry. Persistence is a challenge. This is data from the iAdherence database, almost 70,000 patients from close to 100 studies on various diseases. And you can see that in general, adherence in hypertension is round about 50%. But it's not significantly better, let's say, for diabetes, where it's 75%, or hypercholesterolemia, where it's also round about 75%. So adherence in all chronic cardiovascular diseases is a challenge and needs to be taken into consideration. And also relevant to consider is that adherence is dynamic, and there are some patterns that should be remembered. This is the Doppler. The Doppler misses a dose here and then, and you can see this patient here now. These are the intakes of the medication, and where the amber line is, that is where the patient missed the dose. So sometimes he was taking it, sometimes he was not taking it. Then there are certain patients who drop out, right? So they continue the medication before the treatment plan was completed, because you said, you prescribe a drug, long-term treatment, but the patient dropped out and discontinued therapy. There are holidays that can be taken, drug holidays. This is the vacationer, where you can see that during a certain time period, the patient was not taking any of the medication and just stopped adhering to the medication. Then he or she came back on treatment and persisted on the medication. And then the forgetful one, which is very hard to detect. So in principle, that patient is adherent, but here and then the patient indeed stops taking a medication. And it's very hard to detect, because if you don't measure it at the right time, you'll miss it. Because when you see the patient here, when he has taken the medication, you will not see any non-adherence phenomena. But if you would see the patient by chance, just on a day where he or she was not taking the drug, then of course you would be capable of seeing non-adherence to medication. What are risk factors for non-adherence? So what are the red flags? When should we consider that non-adherence is prevalent in one of our patients? Whenever you see patients at young age, patients with cognitive impairment, patients with depression, and patients with so low socioeconomic status. These are risk factors for patients to develop non-adherence. There are certain diseases that are associated with non-adherence, and most and foremost are asymptomatic diseases. And unfortunately, hypertension is an asymptomatic disease, a bit like lipid disorders. You can talk to patients, you can tell them how important it is to adhere, but if you don't feel pain or any other complication of symptom or complication of your disease, you probably don't take the medication as rigorously as you would do when you know that there are symptoms associated to the disease that you can cope with the medication. Whenever chronic diseases come into play, and there is a lack of risk perception also that associates with non-adherence to therapy. What should we take care of as physicians? Consider higher treatment costs as being a barrier to adherence to medication. Don't play around with high pill burden and very complex treatment regimens. Make sure that you have a simplistic, straightforward medication regimen in place so that makes it to make it the patient easy to follow that prescription, to adhere to the agreed medication plan. Adverse drug effects, very importantly. So we know that drugs with a lot of side effects are not well adhered by patients. Doubts about efficacy, that's also bad. So when you prescribe a drug where the patient is not convinced that it lowers blood pressure or lowers LDL cholesterol, then the likelihood of not adhering to therapy is very high. Lack of awareness of treatment benefits. So show the patient what it means to lower blood pressure by 10 millimeters of mercury, that improves cardiovascular morbidity and mortality by 20 to 30%. Show them what the expected and talk them through the expected blood pressure change and what it means to take the drug short term, but also mid and long term. Treatment complexity for sure promotes non-adherence. This is a study that we have compiled a couple of years ago, where you can nicely see that the number of medication associates with non-adherence and the dosing frequency as well. So in patients who were non-adherent, the average number of antihypertensive drugs prescribed was 5.3. In patients who were adherent, 3.4. So clear association between the two. And the same for daily doses and the frequency. So use drugs with long half-lives, simple treatment regimen, single pill combination therapy helps to significantly reduce pill burden and thereby improve adherence to medication. Dosing time, another aspect to be discussed. We have learned from a couple of trials now that evening doses are those that are most frequently missed. So whenever you can, don't use nighttime dosing for any of the chronic cardiovascular disease treatments that you prescribe to patients. And make it very strict and standardized to patients. The best is to connect medication intake with activities of daily life, such as toothbrushing, newspaper reading, the first coffee, I don't know, whatsoever, opening the door, getting out with the dog. Make sure that the medication intake is associated with activities of daily life so they don't forget. How should you ask for non-adherence? It's not like, don't approach the patient by saying, did you take your tablets? Of course, the patient will say yes, or some patients say no, but that's not helpful, right? The best question is, how often in the past 7 days did you forget to take your tablets? So you're assuming already that the patient is not adhering, and you kind of open the door for him to not please you and say yes, because you are asking him directly, did you forget to take your tablets? And how often did you forget to take your tablets? Which of your medications do you manage to take regularly in everyday life? And which one less so? And when you feel better, do you sometimes skip your medication? And be empathic, right? I can tell you, for me personally, it's very hard to adhere to medication plans. So it's the same for patients. Be empathic and let them know that you appreciate the honesty and also their response to your question. Methods to assess drug adherence, we've spoken about it. Interview, questionnaire, pill count, refill data, witness drug intake, drug assessment. It depends a bit on your configuration, but also on what you want to achieve with your patients. What are methods to improve adherence to medication? That's very relevant here. Healthcare systems need to provide drugs. The best is to provide them for free, because we have seen in various geographies now that those geographies where drugs are available for free or at very low costs, these are the geographies where medication adherence is highest. Healthcare providers, we need to educate the patient. We need to counsel them. Shared decision making, it's not compliance, it's adherence. So discuss what you want to achieve in the individual patient. Take his preference seriously into consideration. Monitor and speak also across disciplines about adherence to medication. So talk to the GP, talk to the internist in charge to make sure you're not forgetting anything. Patients can be engaged in self-management exercise. You know, there are reminders, available apps, pill organizers that improve adherence, that make it easier for patients to adhere to medication. And what I said is, you know, fixed routines is exactly what I was mentioning, which is linking medication intake to activities of daily life. We know that, you know, smartphones work well also in reminding patients on taking tablets regularly. This is a meta-analysis where digital reminders have been assessed in short-term adherence. 16 randomized controlled trials, 2,700 patients with chronic diseases, and you can see that the likelihood of adhering to therapy was double as high when digital reminders were used as compared to non-digital reminders. I mean, and this is very simple, right? You get an alert on your phone, you have to click, yes, I took my medication, and then the system also stores the information to patients. What is a bit less clear is on whether or not this improves long-term adherence. This is an RCT with 1,400 patients after an acute coronary syndrome with weekly notifications. And you can see that, you know, across board, long-term, you were not able to improve adherence to second antiplatelet therapy, statins, ACE inhibitors, ARBs, beta blockers, or aspirin. So short-term, yes. Long-term, there is a question to be asked. What about treatment? Simplify treatment, reduce the dosing time, and of course, choose drugs that come with minimal adverse effects so that patients enjoy adhering to the medication as well. And the easiest way of improving adherence is really the use of single pill combination therapy. This is a study, 82,000 patients with hypertension, where you can see that just by combining ramipril and amlodipine into a fixed dose combination, you significantly see higher proportions of patients with good and very good adherence to therapy. And fixed dose combinations also increase the time at target range. So you define a certain time at target range, and when you do so, you increase the chances of being at that time at target blood pressure by almost 20%. So significantly higher proportion of patients in the fixed dose combination therapy group achieved time and target range. And this is very important. And also, adherer patients with higher adherence to medications are those with fewer heart cardiovascular events. This is a study from the Lombardy region in Italy, 44,000 patients. Some of them were started on 1 antihypertensive drugs, 37,000, and 7,500 patients were initially treated with a 2-drug fixed-dose combination. And look at the numbers here. Any cardiovascular event, minus 15%. Ischemic heart disease, minus 27%. Atrial fibrillation, minus 50%. So you're not only simplifying therapy, but you're also improving morbidity and mortality of patients. Larger prescription supply improves adherence. That's also an easy to be implemented recommendation, right? This is from the US, 30-day versus 90-day prescription after acute myocardial infarction. And you can see that across board, statins, E2, Y12 inhibitors, beta blockers, ACE inhibitors, ARBs, just by prescribing a larger package, 90-day package, you significantly improve adherence to medication in these high-risk individuals. So let me summarize my talk by saying that non-adherence is very common. We know that above 10% of all patients present with primary non-adherence. More than 50% of all patients become non-adherent at 1 year of treatment. Non-adherence to medication is a dynamic phenomenon. Adherence decreases and may also increase over time. And non-adherence worsens the prognosis. Almost 10% of all cardiovascular events are related to poor adherence and are thereby principally reversible or preventable. Treatment complexity is the most important modifiable risk factor. More medications means more frequent doses, and that then also leads to worse adherence to therapy. Actively ask about non-adherence whenever you counsel patients, whenever you see patients. It should be done in an open, non-judgmental question. Simplify therapy whenever you can. Use single pill combination therapy. Use those drugs with long-acting formulations, and establish routines in daily living, in daily life. Communicate at eye level and stay persistent. It's about patient education, explain treatment goals and benefits, understand individual barriers, and provide regular follow-up to patients to address problems in a timely manner. With that, I'd like to thank you very much for listening, and I'm handing the microphone back to our moderator.
Thank you, Professor Felix Mahfoud, and you have given us a very brief but a very informative presentation on the adherence for the treatment of hypertension. And as you mentioned, that poor adherence may be related to the poor blood pressure control, as well as the increasing the probability of cardiovascular risk. And there is many aspects to could be attributed to patient poor adherence. I agree with you that the patient's portrait should be remembered in clinical practice, that such as those at a young age with cognitive dysfunction, and also those in the low social economic status. But some disease still contribute to the poor adherence for the treatment of hypertension. I think that one of the solution for the poor adherence for the improvement of hypertension control may be the intensive and extensive use of single pill combination, and as well as we need to intensify the patient's education at the same time. So I think that very informative presentation. We will move on to the second presentation by Professor Jing Li, and I hope Felix will join us for panel discussion for a while. Thank you so much. The next speaker, Professor Jing Li, will give us a talk about the focus on medication adherence in hypertension management. Jing Li, please.
Yes, Dr. Jing Liu and all the colleagues. Firstly, thank you for having me here to communication with our colleagues. Today, I will show the medication adherence in patients with hypertension. Okay. So just as the Professor Felix mentioned in the last presentation, so the adherence, medical adherence is very important in the hypertension management. So according to the definition, the medication adherence refers to the extent to which patients follow treatment recommendations after clinical consultation, including correct timing, dosing, and dosing frequency and treatment. So we use compliance, adherence, persistence, concordance, all this for terminology to have the meaning of the patients accept the advice from the doctor and take medicine. But now we use adherence. This is the I think the better word to reflect the agreement, cooperation, and partnership. This is the method to assess medication adherence. We use direct method and also use indirect method. All these things Dr. Felix have mentioned, I will say it shortly. So first, the direct method, if patients stay in hospital, it is more easier for doctor and nurse to observe whether the patients take the medicine. However, if the patient is not don't stay in the hospital, it's very difficult. So we use the self-report and the questionnaire to assess medication. However, the accuracy is not very good. We use some special indicator, for example, medication persistence ratio and the proportion of day covered to describe whether the patient have good adherence or not. So for the patient with hypertension, there are some theory that the hypertension require long-term and often lifelong treatment, but the non-adherence rate globally to hypertensive agent is almost 40%. So this I have mentioned before. So if we want the patient have good adherence, for example, this is the picture show. The medication prescription is only the initial step, but the patients need to start treatment, but they may concern about, firstly, the prescription refill, for example, the cost. And they also may have insufficient information to know the medication is so important. So this is all cause no initiation. Another, some patients think the multiple tablet is so complex, especially for old people. So this cause the poor adherence. And also some patients afraid of side effect. They also consider whether the medicine is good or not, whether they take have some side effect, liver function, renal function. This is why the patient refuse to accept the medication a long time. So why we talk the medication adherence? So firstly, in the hypertension patients in China, so we have a health target in 2030, but so far the control rate of hypertension is still very low, far beyond supposed. As we call, there are a lot of reasons to explain to why the patient's control rate is very low. But today, I would like to only focus on one thing, is medication adherence. So there is a survey, according to the different cross-sectional survey, we could find if we use the indirect assessment of medication assessment we found in patients with hypertension in China. The most surveys show that the medication adherence below 50%. This is only one exception. It's in Shanghai. The medication adherence is above 80%. So we know Shanghai is the largest city in China. They have relatively favorable economic conditions, abundant medical resource, and all the patients maybe have a relatively higher education level. So they have a higher medication adherence in China. But most area, the medication adherence below 50%. This is also another survey that shows why the patient have very low blood pressure control rate. So you can see this is the complex dose titration, insufficient efficacy and monotherapy. Look like this is the 70%. It shows that the poor adherence is the main reason of low blood pressure control rate. So look at this survey, this study. This study is a meta-analysis of 4 studies, including more than 1.69 million patients with hypertension. They show if the poor medical adherence exists, this is significantly increase the risk of cardiovascular and all-cause mortality. Also, poor medication adherence also increase the risk of complex outcome in patients. Especially important is the increased risk independent of blood pressure reduction. According to these studies, whether the patient have good or bad blood pressure control, if the patient assessed by the questionnaire show there are poor medication adherence, patients still have the high risk of events. This is the way it shows that medication adherence is very important. Even the patients have relatively better blood pressure control. This is also have high risk. This is another study show the short-term benefit of if we improve the patient have poor medication adherence. If we improve the medication adherence patients, what will happen? Firstly, from the short-term benefit we found, no matter systolic blood pressure, diastolic blood pressure, and the mean arterial blood pressure, the short-term benefit include the better blood pressure control. Also, we have some study on long-term benefit. If we improve medication adherence, the long-term benefit is reduced risk of cardiovascular and cerebrovascular events. This is a long-term 3 months. According to the hypertensive medication adherence, the better adherence and the lower risk of cardiovascular events. Okay, we have mentioned why the medication adherence is important, because they have help the patient to reduce, it's associated with a reduced cardiovascular risk and all-cause mortality. So far, this is a very important question. How could we increase the patient's medication adherence? So firstly, from the patient's treatment, we can find that usually the clinical practice tell us the most patients with hypertension, they need to use more than one drug to control blood pressure. In the SPRINT trial, they also suggest that the most patients take 2 to 4 medications to reach the intensive treatment group, intensive treatment and standard treatment. However, let's look at the dosage and the frequency and the adherence. So if the patients need to take more than one drug to control blood pressure, however, if the patient take too much drugs, there will decrease the adherence. So if the patient take more than 3 drugs, it's associated with 15% reduction in adherence. Also, the dosing frequency is also an important problem. If the patient take more than 2 times per day and compared to less than 4 times, the reduction in adherence is about 22%. This is why in the guidelines, they recommend the patients take, especially take the more than 2 drugs, initiate treatment, as they recommend SPC, a single pill combination. This will, because this kind of medicine, they can reduce the patient's time, the drug number, and also the dosing frequency. This is recommended by the guideline globally. But look at the data in China. There is real-world evidence from China that show more than the majority of the Chinese patients take only one medicine. It means that the patient only take medicine, the blood pressure is not very well controlled. And also, we found the patient use SPC is less enough. In the patient, only less than 30% of patients take SPC. And for the initial treatment with SPC, the only 12.7% in Chinese patients with hypertension. So we can suppose that the patients have more than 2 or 3 drugs per day, and maybe take 2 or 3 times per day. This will reduce the patient medication adherence and cause less controlled blood pressure. This is evidence from last year. This is a comparison between the SPC and the free drug combinations. So we found from here, if we look at the medication adherence rate, if the patients take SPC, they have better medication adherence rate compared to free combination. However, look at this, they're also very interesting. So even patients take SPC, they still following the usage of the medication, they still have decreased medication adherence. So it means that SPC can increase the medical adherence compared to free combination, but the SPC cannot solve all problems associated with medication adherence. Now, look at the events. The low risk of cardiovascular events and mortality was found in patients with SPC compared to patients taking the free drug combination. This is also the reasonable result. That is the lower cost with SPC. This is also the data from real-world evidence. They also compare the SPC and the free combination therapy. They found that if the patients take SPC, they are more easier have reduced the risk of all-cause mortality and compensate events. So in the market, so we found the SPC, for example, the RAS inhibitor and the CCB, and the RAS inhibitor and the diuretics. This is very commonly found in the market. So we can use this kind of SPC in the treatment, especially in the initial treatment for patients with hypertension. So this is also special SPC. We call it the B and C, the beta blocker and the CCB. This is a little bit different compared to the SPC just mentioned in the last slide. So because the beta blocker, they can reduce the heart rate. So if we use B and C, beta blocker and the CCB, especially for the better blood pressure control, we can find it can reduce the patient's heart rate. This is also a meta-analysis about the B and C that show the better efficacy and safety. Especially the mesolar amlodipine SPC show the lower adverse events rate. This is the data from a meta-analysis. This is also the data, the multi-center cohort study in China about the B and C SPC for blood pressure reduction. I can found that the B and C, they have a very good blood pressure control compared to free drug combination. Okay, if we talk about SPC, we still mention the health economics. Early, the SPC is more cheaper. It has good health economics compared to the free drug combination. Also, this is the data. So we just mentioned the SPC is the C加B, A加D, and this is a 2-drug SPC. This also study uses 3-drug SPC versus 2-drug SPC plus a third medication, freely combination. We found that the 3-drug SPC have the better extension of life expectancy compared to the 2-drug SPC plus third medication. Okay, we just talked the SPC. The SPC, if used in the clinical practice, firstly, for the patient, they may meet the patient's expectation. For example, we use drug simply. We use drug cheaper, and we use drug with less side effect. As for the physician's expectation, the SPC also meet the physician's expectation. For example, though, we can improve the patient's medication adherence and make patients take the hypertensive agent a long time. And we have achieved the good blood pressure control. And we have a great treatment efficacy. And we have a less side effect. This system actively have the better tolerability and fewer health literacy barrier. I think this is why the guidelines recommend SPC as the initial treatment for patients with hypertension. So let's have a summary. So the hypertension is maybe is the #1 risk factors for cardiovascular risk globally. In China, we have a very severe challenge because the control rate is relatively low. But why the patient have relatively low blood pressure? One reason is patients have a poor medication adherence. If we want to improve the patient's medication adherence, we need to take some take some measurement to improve that. At least one approach is to use SPC, the single pill combination, to improve patients' medication adherence. So in the guideline, they recommend the SPC used as the initial treatment for patients with hypertension. So from the real world data, we can know that SPC compared to free drug treatment can improve the patient's blood pressure control rate and can reduce the patient's all-cause mortality and cardiovascular risk events. This is an emerging trend in combination therapy, although in China, according to the data mentioned before, the use of SPC is not very high, but I think this is a trend. So more patients will welcome to use SPC to simplify the medicament usage, and the doctor is also easy to prescribe the SPC because they can increase the patient's medication adherence to help them to have good blood control. Okay, this is my presentation. Thank you for your attention.
Thank you for Professor Jing Li. Give us a brief presentation on the evidence of poor adherence and how to resolve this problem. He has mentioned many evidence from China and all over the world. And I think that we move to the panel discussion. We will welcome Professor Li and Professor Zhuang Tian to join us. As you can see from screen, that we have 5 questions and topics here, and I think that the discussion was not limited to these topics. We can share our experience or ask questions for discussions. The first one is about how to realize the adherence improvement. There is many new technologies, such as we can use urine drug metabolic screening, and also we can use some smart pillbox to reminder the patients to take antihypertensive drugs, as well as some new digital therapeutics. So what's your experience, Felix, in your hospital or in your country? Is there such a new technology can be used in clinical practice?
Yeah, we don't have it. I mean, we have drug metabolite screening here available at a relatively low cost, I would say, but we don't utilize this in all patients. I guess the first step is to ask patients about their adherence, then to assess it systematically using scores or using questionnaires. And then easy things like smart pill boxes are to be implemented. Or if you really want to check whether a patient is adherent to medication, do a directly observed therapy. You know, ask the patient to take the tablets, place the ambulatory blood pressure monitoring on the same day, and then you know when blood pressure is being significantly reduced, this patient was very likely not adherent to therapy.
Okay. Any suggestion or experience from Li, Professor Li?
Hi, thank you, Professor Liu, and thank you, Professor Felix and Professor Li. It's my great honor to attend this conference, and I am very pleasure to listen to the all distinguished professors' lectures. And I can share my insight and exchange ideas with all of you. Today's subject, hypertension adherence, maybe has a very new conceptions for me. So as a cardiologist, our work maybe need to extend it for beyond simply writing prescriptions and just only monitoring patients' blood pressure value. Maybe we must focus on whether the patients can persistent or can't persistently taken the medicine, and maybe the smart pill box, just like a clock, or maybe they can send musics on Tian for the patients and alert them to remind them to take the medicine. It's great for the elderly patients. And maybe from the Felix lectures, I knew that maybe the compliance is not the how how meaning of their adherence. Maybe adherence, we need to focus more, maybe just like the medication, for we need to know where we need to know the as a cardiologist, maybe we need to the the lectures made us realize that the every clinic decision or maybe every small detail we handle, it's close linked to the outcomes, whether patients take medicine regularly and maybe the blood pressure reaches target levels, and maybe we accomplish the goal of the hypertension treatment. We need to focus on the long-term goal, just like protecting the patient's heart, brain, kidney, and vessels. So inspired by today's section, we need to reflect that on the daily prescription practice, whether we deliver the individualized treatment for every patient. And maybe in China, we are a developing country, and we need to take patients. Social economic conditional into our considerations, and whether we reduce the unnecessary hospital visiting for the elderly patient. If we can prescribe more medication for them, maybe they can it can increase the adherence for the disabled patients. So we should to draw lessons from the large-scale clinical trials to learn how to apply the standardized assessment indicator or objectively evaluate the patient's medication adherence, not just not just focus on the take the medicine regularly. Maybe we have the many assessment about it. And from the Professor Lee's lecture, we maybe most of the elderly patient, they are the higher blood pressure. So most of the Chinese patients in our country, maybe cause China suffer from high hypertension prevalence and long blood pressure control rates. So the poor medication adherence is the primary barrier to reach their target blood pressure levels, and maybe we are related to the increased cardiovascular risk and mortality. So most hypertensive patients maybe they required combination therapy. Yet maybe SPC, in brief, SPC stand out as an optional solution. The one tablet maybe can improve the antihypertensive efficacy and deliver better, maybe the long-term patient prognosis, and maybe one tablet and once a day, maybe the patient will persistently take the medicine. So for the elderly patient, maybe the simple therapy is bad for them. So the smart assessment and the music pill boxes, and maybe we need our cardiologist and physicians, and maybe our cardiovascular nursing and our community hospital, maybe we can work together and make their better prognosis. Thank you.
Thank you, Professor Lei. The second question is focus on the older population, because in this population there is always a lot of disease comorbidity in one person, such as hypertension, dyslipidemia, and chronic heart failure, and so on. And the question is how to balance the intensify for blood pressure reduction and the reduce of pill burden. Is there any best balance during the treatment for such a population? I want to ask Professor Jing and Zhuang Tian to give some answers, because they have experience for the treatment for disease in the elderly. Professor Jing and Zhuang Tian.
Yes, Dr. Liu, that's a very good question. Is how to improve the medical adherence in patients with very old age. And so in our department, so you have the very high age population. So it's relatively difficult compared to the middle and young age people. Firstly, you look like the patients know that the medication, the treatment is essential. It helps them to improve the life quality. And the second, you want to make patients take medicine, you have to make them reduce the concern of the side effect. Some old people, they especially focus on the side effect. For example, the liver and the renal function, and whether this medication can increase the risk of the consciousness loss. Some patients to ask the patient always ask the doctor always ask doctor whether the medication have a side effect. So in our department, so before we start the treatment, it's better to start initial treatment. We usually have to discuss with the patient's relatives and the patients themselves to why we use this medicine and what indicator we need to observe to avoid the side effect. Sometimes after the patient is discharged from the hospital, whether they take medicine, it depends on the agreement between the patients and the patient's relatives. So we not only talk with the patients, but also talk with the patient relatives, let them to help us to observe the patient's treatment to improve the patient's medication adherence. Doctor and the relative can have the effect to take some effect. Another is usually the patients have a multi-drug treatment, multi-drug usage. If the patients have hypertension, they need to take a hypertensive agent. Patients have diabetes, coronary artery disease, and cerebral vascular disease. They take a lot of medicine. If we use this kind of patient, we have to simplify the patient's medication regimen. Sometimes we can tell the patient that maybe the SPC is a very good candidate for the old people, especially patients to take a multi-drug. Also, if the patients take a lot of medicine, it is very important to reduce some medication, which is not very important. Or maybe they have side effect of the interaction with other drugs. This is what we often do in real practice in the geriatric department. Okay, this is my answer. Thank you for your question, Dr. Jing Liu.
Thank you. Any comments from Zhuang Tian?
Yeah, Dr. Liu and Dr. Li and Dr. Felix. I totally agree with what both Dr. Li said. for the elderly patient, maybe we will choose some long-acting medicine and more effective in elderly patients, such as the diuretics, I think, is long-acting and less side effect, and maybe it's proper for elderly hypertension patients. Another, if the patient needs to use many kinds of medicine for different disorders, such as if the patient has diabetes, maybe we will choose some medicine for the diabetes, also have the antihypertensive effect, such as SGLT2 inhibitor. Maybe it can help to control the blood pressure simultaneously for the blood sugar. And I think maybe I have a thinking that if we can have some medicine just like glycerin for the lipid, if we can get a medicine just one shot for 3 or 6 months, maybe I will to improve the adherence of the blood pressure medicine. So we hope such kind of medicine will to the our experience, we can get such kind of medicine just like glycerin. I think it can improve the adherence greatly. Yeah, that's my opinion. Dr. Liu.
Thank you, Zhang Tian. The third question is about shared decision making. I want to ask Professor Felix Mahfoud, can you give us some experience for the shared decision making in your clinical practice, especially such as those who are indicated for device-based treatment, such as renal denervation? So
absolutely. Yeah. So I actually start discussing this with patients as soon as I first either recognize that they are non-adherent to medication. So patients who are unwilling or unable to tolerate antihypertensive drugs, these are patients where I consider renal denervation. But the larger proportion of patients are patients on 3 or more drugs. And then before I escalate to mineralocorticoid receptor antagonists, namely spironolactone, I discuss with my patients whether they are willing to consider denervation as an option. I explain that this procedure can lower blood pressure additionally to medication in the range of around about 10 to 20 millimeters of mercury at long-term follow-up. The risks are minimal, and then the discussion starts. And I would say 1 out of 4 patients is interested in a procedure to lower blood pressure. Not everybody, but certain patients are.
Yeah. Any comments from Jing Li? Jing Li also have experience for the interventional cardiology. Jing Li?
Yes, I'm here. Yes. So I agree, Dr. Felix's comments. So especially in the clinic, in the clinic. So how to make the treatment for the patient, for different patients. Some patients, so in our department today is my outpatient work. So some patients, this is a very good question. So how to make the patient from the passive to the active, to active. They want to control and manage themselves. Some patients, even with maybe it's not very old, you ask what kind of medicine you take. I don't know. I cannot remember. Just the doctor let me take medicine, and I just take it. So, what is your blood pressure control? Do you measure blood pressure? No. Why? Because the doctor asked me to take medicine. I just take medicine. That's all. This is a very complex phenomenon, I think. Some patients is very active. Some patients ask the other patients, ask whether the medication can take a long time, and what they need to notice in the daily life, and whether this medication have some effect. Some patients is very active. So in the department, in outpatient departments, we only have a relatively short time to communicate with patients. So if we want to do the very high efficient work, that means that they decide both doctor and patients. I think the education, I think, is very important. To let the people know, the patients know that they need to take part in the treatment. They need to take part in so how to deal with the problem during the treatment, during the management. I think it's really important, but not like the patients only think that treatment is the task of doctors. I just need to take the medicine. So even if the patients think, oh, I need to take medicine, and the doctor give me the prescription, doctor, they easily have the poor adherence because everyone told him he will listen. He will think, oh, this is reasonable. The doctor let me to take medicine. Maybe my relatives, maybe my neighbors say, oh, this medicine is not very good. You don't need to take it. So I think makes the people to change to the active management. Management is very important, Dr. Liu.
Okay, thank you. The first question is the early initiation of SPC could enable rapid blood pressure control as well as the building of treatment confidence from the patients, and could this procedure can make some help for improvement of long-term adherence? I think the answer is yes. So the fifth question is also about the initiation of SPC as early as possible. But in the clinical practice, we have to face the doctors' treatment inertia because many doctors will not likely to make some change for their initiation for the prescription of the blood pressure lowering medications. So how to resolve this problem? I want to ask Felix to give a brief answer with your experience.
So I think, and this is also reflected by the current guidelines, that we should aim to achieve target blood pressure values within 1 to 3 months. So this is the time period where we have to see our patients if required. And when blood pressure targets are not achieved, then we should up-titrate medication rapidly. And we've also seen by evidence, supported by evidence, that the more quickly we achieve target blood pressure values, the lower is the cardiovascular risk of patients. So that's definitely something to consider. And this also improves adherence at long term. When patients recognize the drug work, the drug lowers blood pressure, everybody's happy. That should certainly also help the patients adhere to medication.
Okay, thank you. Any comments from my Chinese colleagues, Dr. Lei and Zhuang Tian? Any comments for the final questions? Professor Lei, you are muted. Microphone.
Sorry for it.
Okay.
In my experience, maybe just like the Felix said, maybe the early initiate of the SPC will be effectively boosting the long-term adherence. Cause SPC maybe can quickly stabilize the blood pressure. We can achieve the target blood pressure value, and letting patients see the touchable treatment benefits and gain the confidence in the therapy and gain the confidence from the doctor. So if the one simple pill can make the blood pressure become maybe just like the normal, so maybe the daily dosing can simply take maybe the positive early outcome motives the patient can consistently take the one pill just like SPC. So maybe we need to realize most of our patient maybe need to the combination therapy, and SPC have their maybe their cost effectively and can make their patients gain confidence from the therapy, so it's better for the patient and for us. Exactly, maybe from the 2016, the guidelines also declared that the SPC is better for the most of the patients. So we need to learn from the guidelines and the scan trials and make the early initiate of SPC can exactly exactly make truth in our clinic. Maybe it's better for the patient and for our insurance. Thank you.
Thank you for sharing your experience and ideas. Any comments? Zhuang Tian?
I think it's not too hard for transfer medicine to SPC, because I will tell patient just I will change one medicine for you. SPC is just one tablet, so you change one to another one tablet. I don't think it's very hard to communicate or persuade the patient to choice. Just so this is the better way for the SPC. It look like a one tablet, but maybe it will contain 2 or 3 anti-hypertensive medicine. So I think this is the advantage of the SPC.
Okay.
Just the one for one.
I know that the major treatment inertia may be from the doctor. So if you can make some educations, most of the patients could accept your protocols and use of SPC in their treatment of hypertension as well as other cardiovascular disease.
Yeah.
So if no questions, as the time is limited, I have to make a conclusion, and I would like to thank Professor Felix Mahfoud, Professor Jing Li, Professor Lei Li, and Zhuang Tian from China and from Switzerland, give us a very nice topics about adherence during the treatment of hypertension. And I think that adherence, non-adherence or poor adherence may be one of the biggest barrier for improvement of blood pressure control, not only in China, but also in Asia or even in other parts of the world. Despite that, the single pill combination use may be not the resolve all the problems of adherence, but it is a very practical procedure to use as early as possible, because in China and other countries, I think that in recent years, many SPC can be accessible and available and affordable, and I think we need to overcome our inertia, especially at our end from the medical professionals. At the same time, we need some educations, and we need to use the new technologies such as digital therapeutics, as well as some smart pill box reminding the patient to taking their medications. I will thank all of the doctors and professors who are involved in today's webinar, and we will thank a lot for the organizer, Asian Heart Society, for such a great meeting, and I want to say goodbye. See you later. Bye bye.
Thank you very much. Bye bye.
Bye bye.
Bye bye.
Bye.